Hello friends, I am Dr. Kulkarni and this is part 2 of the presentation on bias in epidemiological studies. In part 1 of the presentation, I have discussed about what do we mean by bias, what is the difference between bias and random error, and what are the types of the bias. And among the various types of the bias, in the part 1, I have discussed in detail regarding the selection bias. In this presentation, we will discuss about the remaining two, that is the information bias and the confounding bias. The information bias is also called as classification bias. Any systematic difference from the true measurement that arises in the collection, recall, recording and handling of the information in the study is called information bias. It also includes how the missing data is dealt with. Any mistakes about dealing with the missing data is also included in the information bias. The major types of the information bias are misclassification bias, observer bias, and reporting bias. The information bias is possible in observational studies, particularly those with retrospective designs, but they can also affect the experimental study. So information can practically occur in any type of epidemiological studies, but it is more likely in the observational types of the studies. The first among those is the misclassification bias. When the individuals are assigned to a different category than the one they actually belong to. While you are making the study on a particular group of participants, you may be dividing in them groups and subgroups. The groups may be done for the purpose of further analysis, and if that method of grouping and subgrouping is improper, then the misclassification bias is said to have occurred. So individuals are here assigned to a different category than the one they belong to. It can occur for exposure or for outcome. So you may be categorizing the exposure, mild exposure, moderate exposure, heavy exposure, something like this. Or outcome, wherein you are categorizing them as mild disease, moderate disease, severe disease. And if the criteria for them making these are ambiguous, they are not objective, then the misclassification bias is likely to occur. Person belonging to mild is put in by mistake to the moderate category. Person belonging to moderate is put into severe category, or the reverse way. So if this thing occurs, it is called as misclassification bias. So this occurs because the diagnostic methods, the questionnaires, the scoring system which classify are not precise for categorizing the individuals into mild, moderate or severe category of exposure or mild, moderate, severe category of the disease. The diagnostic methods and the questionnaires and the scoring system which is used for this categorization are not precise. They are not pre-tested. If this mistake occurs, then we say the misclassification bias has occurred or is likely to occur. There are two types of misclassification. One is the non-differential misclassification and the second one is the differential misclassification. Non-differential misclassification is a systematic error that occurs equally in all groups. So this error is occurring equally, in equal quantum, in equal quality in all the groups. Error is occurring, but it is occurring throughout the population, throughout the range of the population, in all groups and the subgroups of the population. So that is called as a non-differential misclassification. So it tends to underestimate the effect. So if non-differential misclassification is occurring, it tends to underestimate the effect. The example is weighing machine is set not at 0. So it is set either at 0.5 kilogram or 0.1 kilogram, or it is set on the other side. The zero is on the left side of the pointer. So such type of error, if it is occurring, is called as a non-differential misclassification, which occurs equally in all groups. The differential misclassification is when the different levels of inaccuracy occur across the comparison groups. So there is no inaccuracy in classifying the mild category, and there is say inaccuracy when you are classifying between the moderate and the severe category. If such thing is occurring, then we say that it is a differential misclassification, or it is occurring between the mild and moderate only, and the severe are very easily diagnosed, and there is no mistake in severe cases. So that sort of thing, if it is occurring, so there are different levels of inaccuracy across the comparison groups. The inaccuracy can occur in the study group and in the control group, and the inaccuracy is occurring at a different level in the study group, at a different level in the control group. We say differential misclassification is occurring. So there are different levels of inaccuracy. So this leads to underestimation or overestimation of the effect. So it will depend on where it is occurring and to what quantum it is occurring in a particular category. So that sort of bias, when it occurs, is called as a differential misclassification. For example, the diagnosis of the disease or the diagnosis of severity in cases is made by the experienced person, professor, whereas the diagnosis of the entity in the control group is made by the junior persons. The follow-up of the cases is made by the senior person, professor, and the follow-up of the control group is made by the junior residents. So here the quality of the follow-up will be affected, and the quality of the follow-up will definitely be better in the study group as compared to the control group, and here the differential misclassification has occurred. If on the contrary the same type of the persons are observing the same groups, that means professor is or the senior persons are allotted the responsibility of the cases as well as controls, then the differential misclassification is not occurring over there. How do we avoid or minimize the misclassification bias? The prevention is done by accurate diagnostic methods. As far as possible, we keep the objective type of diagnostic methods. So there should be objectivity. The subjectivity in the diagnosis should be minimized, and there are methods by which the subjectivity in the diagnosis or classification of the individuals in the groups is not there. That means subjectivity is not there. So there are methods by which it can be done. After the study is there, then we can have what we call as a quantitative bias analysis. We can see, for example, what percentage of cases were followed by the professor and what percentage of cases were observed by the controls were observed by the professor. What was the percentage observed by the cases observed by the junior person? What was the percentage of controls followed by the junior resident? So this is called as a quantitative bias analysis. The quantification of the variable is done, and the quantitative bias analysis can be done. This will minimize the misclassification. It will not totally eradicate the misclassification, but the misclassification bias will be minimized. The next type of bias is the observer bias. Observer bias is a systematic difference between a true value and the value measured by the observer. The value measured by the observer is one thing and actual value is another. And if there is a difference, then the observer bias is said to have been introduced in the study. This is mostly because of the subjective nature of the diagnosis, like imaging, for example, means X-rays, when the diagnostic methods are based solely on imaging. So the diagnosis from the X-rays is quite a subjective thing. Some person may say that the disease is not there, especially in mild cases, is not there. Some may say that yes, the disease is there. So that subjectivity is there. The subjective nature of the diagnosis introduces the observer bias. And this could be inter-observer bias or intra-observer bias. The same X-ray, if it is shown to the same person and if he makes a different diagnosis, this is called as the intra-observer bias, because the same X-ray is shown to him, and one first occasion he says yes, disease is there, and on the second occasion he says the disease is not there. So this is an intra-observer bias that has occurred. Inter-observer means when the same X-ray is shown to to different persons, and the different persons make a different diagnosis, the diagnosis either of the disease or the severity of the disease. So that is inter-observer bias. Some people have the habit of rounding the blood pressure. When you take the blood pressure, some people may round it to the next higher number, some people may round it to the prior higher number. So rounding off, rounding up. So those sorts of things are there, and the observer bias therefore is introduced. So one person who is rounding up, so in that cases, in all cases, in that individual, the blood pressure readings will be on higher side. If the person is habituated to round off, that means round to a prior figure. If the blood pressure is say 81 and he says it 80, if it is 82 he says it as 80. So in such individuals the blood pressures will be biased towards the lower side. All blood pressures measured by that person will be biased to the lower side. And the reason for the observer bias mostly is the experience and the training. So the observer bias therefore can be reduced by training and when the observations are done by the experienced person. The blinding, which is an important technique in the clinical trials, can minimize the observer bias. The blinding is done when for the person evaluating the outcome of the drug. So if such person is blinded for the effect of the drug, blinded for what drug was given, then the observer bias will be minimized. Standardization of measurements. The procedures of taking any measurement must be standardized. The detailing of the steps should be given. Weight taking, for example, whether the weight should be taken with the clothes, with the minimal clothes. So that should be told. Whether the height should be taken with the shoes on or shoes off. So that will minimize, if these instructions are given, that will minimize the observation bias. And the training. Before you undertake the project on the larger scale, the training of the observers must be done, and that will minimize the observer bias. The reporting bias is the selective revelation or suppression of the research finding. So either selective findings are revealed or selective findings are suppressed from the readers. So that is called as the reporting bias. So there could be over-reporting of benefits, there could be under-reporting of harms, and that introduces the reporting bias. This can occur before, during, and after the study. And there are several types of the reporting bias. The first one is the publication bias, wherein the person doesn't publish the results at all. The results are inconvenient and therefore the findings are not published at all. So that is the publication bias. So you may not find all the trials for particular drug being published. Some people may find the inadvertent side effects. The side effects may be unexpected and of the severe type. So there may be, these may be not published, and the published literature are only those which do not show such severe adverse events. So that publication bias is therefore introduced over here. The time lag is the negative results take time to publish. So 3, 4 or 5 trials are published, and then suddenly we find one person publishes that there are side effects of the drug. And then if it is inquired in details, it is found that the previous 4 persons had observed that type of negative results, but they had not published. So negative results take time to publish. Then duplicate publication. Some people are of a habit of sending the articles to 2 journals and make minor modifications. The same data is there, the same study is there, the same sponsor is there, but the data is modified to some extent. Some tables are there in one study, some tables are not there, some figures are in first study, some figures are not in that study. So like that, the same finding but duplicate publication. So that is duplicate publication bias. Then the location bias is the studies of some location are easier to find. You may find the studies conducted in USA more as compared to the studies conducted in India regarding the same drug. So because the journals publishing the articles are more in USA as compared to the journals in India, or the index journals are more in USA as compared to the journals in India. So the location bias occurs where you may find certain studies, certain locations. The studies conducted in certain locations are only published. Citation is the self-citation, citing the convenient publications only. You cite the publications that are convenient to you, and the publications, the findings of which are not in agreement with your study, you don't cite those at all. So that is called as the citation bias. That is the selective reference of the citations introduces the selection citation bias. Language bias, the studies in certain languages are easy to find. For example, in India, studies in English are easy to locate than the studies in, say, Russian language or Chinese language. So because of that, we rely only on the studies published in English, and that reporting bias will occur. Outcome reporting is the selective reporting, is the summary of all these. Is the outcome reporting, that is outcome reporting bias, is the bias when there is a selective reporting including only selected part of the data. The study had say 4 objectives, and only the results related to 3 objectives are published, and the results related to the 4th objective are not published at all. So that is the bias in outcome reporting, that is the selective reporting including only the selected part of the data. This may not necessarily be purposeful, because the journals have a limited space in publication, and all the observations in the data may not be published. But the authors can mention over there that some part of the study is not published, and if you are interested and contact the authors, the information can be obtained. Then the outcome reporting bias will be reduced in that case. But if nothing is mentioned and the selective reporting is there, some part is only included and some part is withheld and not available anywhere for the readers, then the outcome reporting bias has occurred. The outcome reporting the reporting bias can occur before the study, during the study, and after the study. Lesser the say during the study, the better. The reporting bias can occur before the study. The biases that can occur before the study is not reporting the conflict of interest. The study protocol is supposed to be presented to the ethics committee. That is before the study, because the approval of the ethical committee is to be taken before the study. And you do not mention the conflict of the interest in the proposal that is submitted to the ethics committee. So that is the reporting bias that has occurred before the study. Under-reporting or over-reporting, thereby justifying the study. You may say that the drug is very safe, and you just do not mention the studies in which the adverse events were found. You do not mention it at all when the proposal is being submitted to the ethics committee for the approval. So at that time, you under-report or over-report, and thereby you justify your study. Because if you would have said that there are certain side effects, then the ethics committee might take objection, and therefore this type of bias has occurred before the study has started. Non-reporting of planned methods of data collection, analysis, and expected outcome. It is expected that all methods of data collection, analysis, and the expected outcomes must be presented before the ethics committee. That is before the study. And if it is not done, then the reporting bias has occurred before the study. During the study is non-reporting of the statistical or analytical methods or the course to certain persons involved in the study. People do not know. There is a multicentric study, and some people in one center know better about the study than people in the other center. So there is non-reporting of the statistical analysis or methods and the course. Some centers are observing the protocol in a better way, and some centers are not observing that correctly. So that sort of reporting bias will therefore occur when there are multicentric studies during the study. The reporting bias can occur after the study. So you have published the study and you have not reported the conflict of interest to the journal. The article is sent for publication and you have not reported the conflict of the interest. The representative of the pharmaceutical company is one of the authors. The pharmaceutical company is the sponsor. There is nothing wrong if a representative of the pharmaceutical company is in the author, but you hide that particular fact. You are not reporting that conflict of interest in the paper. If you openly say that yes, such and such author is from such and such company and this company has sponsored this trial, then you are not under-reporting, or you are not hiding the conflict of the interest. But if it is this part is not revealed, then it is non-reporting the conflicts of the interest. Selective reporting the outcomes. Only the Good effects of the drugs are published, the bad effects are not published. That is the selective reporting. Non-reporting of the negative results, reporting before completion of the study. The study is yet to be finished, and the person starts giving interviews to the newspaper channels. So that is reporting the study before completion of the study. The study is not completed, not published, and the details of that are revealed to some people. So that is the reporting, and that is therefore a reporting bias that has occurred. Over or under citation of the references. You cite the references that are convenient to you in the paper. You don't cite the references that are inconvenient to you. So that is the over or under citation of the references after the study. That is, this occurs during, especially after the completion and while the article is sent for publication. The prevention of the reporting bias is very important, and much attention is now being given to this aspect. So pre-publication is the in pre-publication stage there could be a prospective registration of trials. Nowadays, especially in India, the clinical trials are supposed to be registered with the trial registry of Government of India, ctri.nic.in. That is the website wherein you register your clinical trial. So the detailed proposal that has been given to the ethical committee, the proposal that has been accepted by the ethical committee, is sent to the trial registry. So that is available with them, and that is available for anybody. It is in the public domain. So that research trial, the study design, the steps, all things are there available for the public by way of prospective registration of the trials. Unfortunately, such type of facility is not available for other study designs, that is for the case control studies or for the cohort studies or for the observational study. In the pre-publication stage, this facility is available now only for the registration in the form of registration for the trials. And each country has got now its own trial registry, and there is a synchronization between the trial registries of the different countries. So people from other countries, say USA, can know what trials are being taken in India and vice versa. During the study, the data and analytical codes are made publicly available. So this occurs in the pre-publication stage at all. If it has occurred in the pre-publication stage, it is okay. But during the study, if some person wants the data and the analytical codes, then that would be a very good step in reducing the reporting bias. After the study, the resorting to guidelines like consort, the many good journals now expect that the articles must be published according to the guidelines for a particular type of the study design. For example, for clinical trials, there are consort guidelines, and they expect that the publication or the article should be written as per the consort guidelines. So nothing is missed. So there are the checklists are there for the clinical trials. Similarly, the checklists are available for the case control studies, cohort studies, for cross-sectional studies, and there are internationally accepted guidelines for these types of the study. So after the study, if the one resorts to the guidelines like consort or the respective guidelines for the case control studies or for the cohort studies or for the cross-sectional studies, then the reporting bias after the study will be minimized. The recall bias is when participants do not remember previous events or omit certain details. So this will happen when the information there is over reliance on the recall of the participant. The information is obtained by recall only, and when there is a selective loss of the memory of the previous events, when the person omits certain details, when the person doesn't tell certain details, then we say that the recall bias has occurred. And the nature is influenced by the subsequent event. Means suppose a disease has occurred and the exposure related to that disease is asked, then the recall will be better in those persons who have suffered from the disease as compared to the person who has not suffered from the disease. So this recall bias is occurring because in both the cases we are relying on the recall of the patient, and there is a differential recall loss. The person with the disease is recalling better about the exposure, and the person without the disease is not recalling the event as the other person is recalling. This is therefore a problem in a case control study and retrospective cohort study. It can also be occur in the cross-sectional study where information is asked retrospectively, that is by recall, that information is asked. So cross-sectional studies are not immune from the recall bias. The longer the duration of the recall, more are the chances of recall bias. You are asking about an event that has occurred yesterday, and you are asking about an event that has occurred 10 years back. So the memory will be naturally better for the recent event as compared to the past event, very past event. So the longer the duration of recall, more are the chances of recall bias. It depends on the age, education, and the perceived importance of the event. The event may be important for the person undertaking the study, but the event may not be important for the person who is responding to the question. So then he will be casually saying, no, such event has not occurred. So that casualness may enter in the mind of the respondent, and that is because of the perceived importance of the event. So it depends on the age, the education, and the perceived importance. The undesirable habits are less reported, especially habits that are related to the disease, habits that are said to be related to the disease that are not reported. The habits that are socially not acceptable will also be not reported and therefore not recalled. So that sort of recall bias will occur. Like for sexually improper practices, the practice of taking the drugs, IV drugs. So with that reference, the recall memory, the person may be recalling, but he will not be reporting those sorts of things. Regarding the sexual behavior, like visits to the prostitutes, that will be less reported because it is an undesirable habit that is to be reported. So that recall bias will occur over there. So it was observed in a study implicating MMR vaccine to the autism. So they wanted to show the relationship between autism and MMR by retrospective inquiry. So what they did was they collected the women with whose child was suffering from autism. So that was the study group, and the control group was the women whose child was not suffering from autism, and they asked the history of MMR vaccine in them. It was found more in the children of the women who were suffering from autism, because the publicity was that the study is being made to show the relationship between MMR and autism. So the women whose children were suffering from autism reported MMR more frequently in a better way than the women whose children were not suffering from autism. The reporting was less in them, and the reporting was not of a good quality in those women. When these records were cross-checked, when the information given by these women in the study group and the control group was cross-checked with the hospital records, then only it was found that the women whose children did not suffer from autism did not report the MMR vaccination, whereas the women whose children had suffered from autism had reported the MMR in a better way. So this is a classic example of the recall bias and how the recall bias can affect the study. If that precaution would not have been taken by the persons, the cross-checking with the hospital records, the cross-checking with the immunization records available with the women or the family, if the cross-checking would not have been done, then MMR would have been unnecessarily be blamed for the causation of autism. But because this precaution was taken, because the recall bias was avoided, because the recall bias was considered and suspected and the preventive measures were taken, the wrong association or the wrong conclusion that MMR is associated with autism was avoided. Hawthorne effect is the effect that occurs when people behave differently if they know they are being observed. So this naturally will be important in studies related to behavior of the person. If the behavior of the person is if the person knows that he is being observed, then his behavior will be different than if he doesn't know that he is being observed. Then when he is not observed or he doesn't know that he is being observed. So concealed observation. So there could be three types. When the person knows that he is being observed, there is a concealed observation and there is no observation at all. So in all these three events, the behavior of the person can be different, and this is called as the Hawthorne effect, which was found in United States when a study was made on the industrial workers, and it was then found that the behavior of the workers differed when they were being observed as compared to when they were not observed. Naturally, the prevention lies in comparing the behavior of the persons when they are observed and the person's behavior when the person is not observed. Or you can take only unobserved events only, or you can have concealed observation when the person doesn't know that he is being observed. The precautions are taken to conceal from the person that he is being observed. So that sort of precautions can be taken. Lead time bias is the bias that is occurring due to incorrect starting time taken while calculation of the survival time. The survival time for a disease, the correct survival time for the disease, is when the pathogenesis of the disease starts and when the person dies. So that is the correct survival time. That is the correct survival time. That is when the disease pathogenesis has started and when the person has died. That is the correct survival time. However, what do? We do not know the pathogenesis, when the pathogenesis has started. So we take this survival time, that the disease has detected and from here he has survived to this time. So we take this as a survival time. That what was the detection time, what was the time when the disease was detected and when the death has occurred. So that is the survival time we are taking. Now, if this is a disease like say cancer, the breast cancer or any other type of cancer for which the screening program is being implemented. So the screening is done in apparently healthy individuals. So it is before the usual detection. So it will naturally occur before the usual detection time. So it occurs over here. And we say that this is the time of the survival of the patients who are screened. And this is the time of the survival on the patients who are, or the persons who are unscreened. So naturally you may say that there is an advantage gained or the life is gained by the persons who are screened. But is this conclusion correct? Because this is the lead time, the whatever extra time appears to have been gained by the persons who have undergone screening is the perceived gain, and that has been obtained only because of lead time. The survival, which should have been calculated actually from the pathogenesis to the death, is calculated from the usual detection in the persons who are not screened and from the screening in the persons who are screened. So that is the perceived survival time in the screened patients, and this is the perceived survival time in the persons who are not detected, and that is the lead time is the gain obtained. And this bias occurs when evaluation of a screening test is done, and one must keep this in mind that lead time bias can occur when you are evaluating the screening and saying that the screening is gaining in terms of survival time. Ecological fallacy occurs when there is a thinking that the relations observed in groups hold true for the individuals. You observe certain relationship between a variable in the groups, particularly the means. So the mean of one group is such, the mean of the second group is B, the mean of the third group is C. So A is the mean of the first group, B is the mean of the second group, and C is the mean of the third group. And you observe certain disease, say the mortality in A, B and C, and you say because the A group had higher mean value, the mortality was higher. The C group has the least mortality, and therefore the C group has the least mortality because the variable showed the least mean among all the groups. So the mistake that we are committing over here is that we are relating the observations in the group and you are applying it to the individuals. So this is called as the ecological fallacy. So in one study it was found, they tried to show an association between the blood pressure and the occurrence of the stroke. So there they found that the mean entry level blood pressure, entry level blood pressure means the blood pressure that was found at the time of the entry in the study. So the mean entry level blood pressure and the stroke mortality rate was inversely related. So it was found that those groups which had higher mean entry blood pressure had the least mortality because of the stroke, and those groups which had the least mean entry blood pressure, in those groups the stroke mortality was highest. So this was the inverse relationship was observed, and this was certainly surprising as to how a disease which we presume is because of the blood pressure, higher blood pressure, and how the mortality can be less in the groups in which the mean is more, and how the mortality could be more in the groups in which the mean blood pressure is less. So the mistake that was committed was then found out when from these groups the individuals who had the higher mortality were isolated, and from all the groups the individuals with high blood pressure were compared with the individuals with the less blood pressure. So individuals from the group 1, individuals from the group 2, and the individuals from group 3 having the higher blood pressure at the time of the entry were isolated, were segregated, and the individuals with less blood pressure were segregated. The records of these persons were segregated, and then the mortality was found out, and then it was found to have a positive association. So at a group level, when the means of the groups were checked with the mortality rates of that particular group, an inverse relationship was found. But when it was checked with the individual blood pressure and the mortality or non-occurrence of the mortality was checked with the individual, a positive association was seen. So such type where the group observations are compared with the individual observations, or the conclusion is drawn from the group observations, and then they are applied to the individuals without finding what happens at the individual level. So the ecological fallacy is said to occur. So statistically, a correlation tends to be larger when an association is assessed at the group level. So association, when it is assessed at the group level, the correlation appears to be larger. And in fact, it could be reverse type of correlation, as it was found in the correlation between the blood pressures of the individuals was found. So that is the ecological fallacy. The confounding is a type of bias. Some people consider it a type of bias. Some people consider it as a separate entity and not as a bias. A confounder, we are trying to show an association between, say, an exposure and an outcome. An exposure and outcome. And a confounder is a third factor which is associated with exposure. A confounder is a factor which is associated with exposure. It is also associated with the outcome, but it is not a step in the causal chain of the outcome. So it is not in the natural history of the disease. It is not a step in the natural history of the disease, but it is just associated with the exposure and the outcome. Then such factors are called as confounders. So it spuriously alters the chances of exposure. It spuriously alters the chances of exposure, and therefore it spuriously shows either the presence or absence of the association with the outcome. So a wrong conclusion is likely to be drawn if the effect of the confounder is not given thought to. So it alters the chances of the exposure, and thereby it distorts the estimates of association of the exposure and outcome. So it is more likely in observational studies, but it is also likely to occur in the case control studies also. So here is an example. So the hormone replacement therapy was very popular some days back for reducing the risk of cardiovascular diseases. So it was found that the hormone replacement therapy, there was a beneficial effect on the cardiovascular disease. The people who were taking the hormone replacement therapy for certain other purposes, the beneficial effect on the cardiovascular disease risk was found in the study. But this was found because the confounding effect of these factors, that is the socioeconomic status and the education, was not taken into account. And this is the confounder, because the socioeconomic status and the education are related to hormone replacement therapy. because the people with better education of the higher socioeconomic status only will take the hormone replacement therapy because it is comparatively costly. So there is an association between the socioeconomic status and education. There is also an association between the cardiovascular disease and the socioeconomic status. So therefore, socioeconomic status and education comply with the conditions that are required for the confounding factor. And when the results were analyzed, the beneficial effect was not seen after accounting for the confounders. There are certain statistical methods by which we can find out whether the confounding has affected this relationship. So this beneficial effect disappeared when the confounding effect with the socioeconomic status and education was taken into consideration, and the beneficial effect was not seen after accounting for the confounders. There are two types of confounding. One is called as a positive confounding, is when the observed association is biased away from the null. In other words, it overestimates the effect. This example which we have given is a type of positive confounding. It is biased away from the null. So we try this. If this positive confounding is there, there will be higher chances of rejecting the null hypothesis, though it is true. So a true null hypothesis will be rejected. So type 1 error will occur over there. So it overestimates the effect. A negative confounding is when the observed association is biased towards the null. So there is more chances of accepting the null even though it is false. So type 2 error will be occurring. So in other words, it underestimates the effect. So the confounding could be overestimating, or confounding could be underestimating the effect. Confounding could be away from the null, or confounding could be towards the null. And that will depend on the relationship between the exposure and outcome and what is the confounding factor is there. So depending on that, whether it is a positive confounding or negative confounding will depend on that. The prevention of confounding at the planning stage is considering that the effect of the confounder will take place and arranging accordingly. But at the analysis stage, the confounding effect can be identified, minimized by stratified analysis. The technique of stratified analysis is done. In fact, this particular study, the stratified analysis only had demonstrated the effect of the confounder. So stratified analysis or multivariate analysis will identify whether a factor will be confounding or not. Whether the confounding effect is there for a particular factor or not, that can be identified with the help of stratified analysis and with the help of multivariate analysis. Propensity analysis and the propensity score is advanced statistical technique or advanced statistical analysis available in many softwares. So propensity scores, in there the potential confounders are used to build the model. So we suspect a particular confounder. So that is used in building the multivariate model. And the cases with high propensity score are likely to have the confounding factor. So you identify the cases with high propensity score, and those will be the cases with the confounding factor. And you find whether the suspected confounding factor is there or not in the individuals, participants in whom the high propensity score was there. So high propensity score means there is more likelihood of confounder being found in those particular participants, and we therefore separate out the persons with a high propensity score and persons with low propensity score, and we find out what are the factors, whether the suspected confounder is present in high confounders or not. If it is not there, then it is not a confounding factor. If it is there, then it is affecting as a confounder in your analysis. So that sort of analysis, advanced statistical analysis, can be made. There is a subclass of confounding which is called as confounding by indication, and these examples are seen in ample in pharmaco-epidemiological studies. This is also called as indication bias. The confounding by indication is also called as indication bias because the word indication is there over here. It occurs when the risk of an adverse event is related to the indication for medical use, but it is not related to the use of the medicine itself. So actually there is no association between the adverse event and the drug in question, but it is related to the indication for which the medication was given, and that's why this is called as the indication bias. For example, the indication is fever over here. For this indication that is fever has prompted the use of paracetamol, and now here the paracetamol is considered as an exposure factor for the outcome, that is asthma and eczema. So the drug paracetamol was given for this indication, that is fever. What prompted the use for the use of paracetamol? What prompted the use of paracetamol? It was the fever that has prompted the use of paracetamol. And then you were studying the causal factors for asthma or eczema, and retrospectively you check as to what drugs were taken by this person, and you find that many of them had taken paracetamol in the persons having eczema or asthma. The control group for these in case control studies will be the persons not having asthma, not having eczema. These persons, there was a less incidence or the prevalence of fever in these cases, asthma and eczema. The control would be the persons not having asthma, not having eczema in case control studies. In this group, you will find the exposure to paracetamol more naturally. And in those persons who did not have asthma or eczema, you will not find the paracetamol being used that frequently, because this fever was not there in those persons. So this bias has occurred, which has affected our conclusion, or because of which we have taken this conclusion, or because of which we are likely to take this conclusion that the paracetamol is the exposure factor for the outcome asthma. Naturally, this type of bias will occur in retrospective studies only. We can prevent this bias in the analytic stage and the planning stage itself. See if the drug paracetamol causes the outcome, that is asthma, for all indications. Suppose we are implicating paracetamol for asthma. Paracetamol was given for fever, but there are other indications of paracetamol. There are other indications apart from fever or myalgia. It could be taken for joint pains. The person is having myalgia, but paracetamol is given. He did not have fever, the paracetamol was given. Person was having joint pain, the paracetamol was given. The fever was not there. So if our conclusion that the paracetamol is likely to induce or is the exposure factor for asthma, then even if the paracetamol is given for the indications like myalgia, for the indications like joint pain, in these persons also the association with the paracetamol should be seen. If it is not seen, then this is an indication bias. But if it is seen that if the paracetamol is given for myalgia, asthma is occurring. Paracetamol is given for joint pains, the asthma is occurring. So then the indication bias is not occurring, and then we can say that the association between paracetamol and asthma is established. Otherwise, it is not established. Protopathic bias is another bias that occurs in pharmacoepidemiological studies. A drug is initiated in response to early symptom of a disease yet to be diagnosed. The disease is yet to be diagnosed, but the drug is given for an early symptom of that disease. The drug then is incorrectly implicated as the cause of the disease. So herein, the early symptoms are there, and that's why a particular drug is given. And then a disease is detected. And when you make retrospective inquiry, you find that this drug is given. You make a retrospective inquiry, you find that this drug is given. Actually, this drug is given was not given for this disease, but this was given for the early symptom of the disease. And therefore, the protopathic bias has occurred in this case. The example is of NSAIDs. NSAIDs, that is non-steroidal anti-inflammatory drugs. So non-steroidal anti-inflammatory drugs were given for pain due to abortion. And when the case control studies were made for the abortion, what are the causal factors, what are the risk factors for abortion, it was found that the abortion patients had high prevalence of NSAIDs being given during the prior period of the abortion. So when retrospective inquiry was made, it was found that NSAID was given, and the controls were the non-aborting cases. Controls were non-abortion cases attending particular that hospital. And naturally, because the pain was not there in those persons, the NSAIDs were not given in those patients, and that's why incorrect association, positive association between abortion and NSAIDs was made, and this was an incorrect because a protopathic bias had occurred in this case. In this case again we can detect the protopathic bias can be detected by analyzing the time lag between the drug given and the disease. So if the drug is given after the early symptoms, then the protopathic bias is there. But if this drug is given before the symptoms, if the NSAID is being given before the symptoms have started of the abortion, then the protopathic bias is less likely to have. So the time of this drug being given, whether it was given before the early symptoms or after the early symptoms, if it is given after the early symptoms and the abortion has occurred, then naturally the protopathic bias is more likely to have occurred. So that's the way by which it can be detected by analyzing the time gas, and it is therefore more likely in case control studies. The strategies for prevention of the information bias could be that the study designs are appropriate for the research question. So this particularly comes when there is a choice between the case control studies and the cohort study. There is equal chance that you can the research question is appropriate for the case control study as well as for the cohort study. Then you must try to find out whether the information bias is likely to occur. So whether the study design is appropriate, because whether you are relying more on the recall, then the recall bias is likely to occur, the information bias is likely to occur. A well-designed study protocol which considers the possibility of information bias. The question could be asked different ways, and the triangulation could be used for obtaining the information that could be included in the protocol. Appropriate definitions of exposure and control. So you must make the appropriate definitions of exposure and control. You can avoid the information bias. Less reliance on recall. So as far as possible, the recall should be avoided. If information can be obtained from the records, you should not rely on recall of the person for that particular information. So minimum reliance on the recall will minimize the information bias. The questions posed are posed neutrally, and the data triangulation, if it is resorted to, will reduce the information bias to a great extent. So this therefore then finishes the part 2 of the study. If you have got any problem, you can contact me at this email ID drapkulkarni@gmail.com. Thank you very much.